Need some technical support again for switching to slides. And Oona Saint-Amand, I hope I pronounce it correctly, will be talking about systemic familial alienation in the context of substance use disorders. And the floor is yours.
Thank you. Thank you very much. Oh. That's not a good sign. Wonderful. Thank you so much for attending this presentation today. It's our pleasure to be here, and it's myself and the co-PI of this study, Angie Hamilton. So we would just like to acknowledge the other speakers. Thank you, Elliot, for that wonderful presentation. We had the pleasure of having lunch yesterday together, and Angie said, please give a shout out to the Foundation of Motivation and Change because they've done such incredible work for FAR. And Anya, thank you for your presentation as well. It's incredible what can happen in 1 hour of television. It's just amazing. So I'm a professor, an associate professor at the University of, Toronto Metropolitan University, and I'm the PI of this study. I'm going to click here. I'd just like to acknowledge our co-investigators and some of our research staff on this slide. As you can see, we have a well-rounded team of researchers, and this study was funded by our Canadian Institute of Health Research. So family caregivers are indispensable yet often undervalued contributors to care, and I don't think I need to share too much more about that with this audience. And the recovery of individuals with substance use disorder often improves because of their involvement. Beyond providing daily care, they can serve as intermediaries in navigating crisis and facilitating treatment. They are often the ones to assist in planning and coordinating long-term recovery. A recent systematic review of the effects of family therapy for persons with substance use disorder found that involvement of family members in treatment yielded outcomes like diminished consumption and improvements in family functioning. Other research suggests that they are often the ones to recognize the first signs of relapse, and they are the ones to connect their relative with service providers. In addition to this, they often serve as sources of emotional support, and the literature highlights how families can be the ones to mitigate the isolating effects of it that comes with addiction. Despite their role in caregiving, family members frequently encounter deeply entrenched systemic barriers that diminish their ability to provide care to their relatives and that further isolate the caregivers. So in this presentation, we're going to discuss some of the real harms of these systemically embedded policies and practices and explore the perception of family caregivers. So the literature is becoming the exclusion of family members is becoming increasingly well documented. We're seeing several scholars examine the various mechanisms that contribute to exclusion. For example, Norgan and colleagues illuminate the closed door strategy, where parents are discouraged from active involvement in their children's addiction treatment due to professional and social norms, perceptions of codependency and treatment within the treatment community. Other authors have discussed passive ways in which service providers advocate for rigid boundaries, implicitly removing the parents from engagement in treatment, and often drawing attention to enabling behaviors while dismissing the supportive role. These authors often suggest that framing parental involvement as codependency reinforces a negative identity, which aligns well with Dr. Orford's discussion yesterday. The authors also reveal that there's an emphasis on detachment-based strategies that encourage familial disengagement. So while these authors have found that in addition to passive exclusion strategies, family members who explicitly request involvement in their relatives' care are often denied access, either being withheld medical updates or refused information about relapse, or being deprived involvement in care planning, even despite their intensive roles as caregivers. Other systemic barriers are related to the prioritization of individualized care over family-based models. It's often perceived that individualized care is easier. Working with families is messy. And some studies have discussed how service providers will selectively decide which family members can be involved, often based on biased assumptions about the family. Other systemic structures related to social service and housing policies have been identified in the literature as reinforcing family disconnection. For example, Gnocchi and colleagues found that some housing-first models require people with SUD to demonstrate complete independence in order to receive services, and in some cases, the system mandated severance and ties with families. A common theme in several of the studies is that family exclusion is not merely incidental, but rather embedded in policy and treatment models and social structures. Legal frameworks surrounding addiction are often create dismissing or distressing dilemmas for families. And so a lack of readily available social services are also a part of the problem. Families turn to law enforcement as a last resort, resulting in incarceration and over medical treatment. And a previous presentation that we did for AFINet looked at the counterculture that emerges when family members are desperate and have to respond in isolation of the system. So this study is co-designed with a community group, and that's Angie. I'll let her, she'll be speaking very shortly, called Families for Addiction Recovery. We use participatory action research principles to guide and design this study. Essentially, we had semi-structured interviews with family members. Recruitment was done through FAR, Family for Addiction Recovery, and we had done 87 interviews between February last year and August. The interviews were around an hour to 2.5 hours via Zoom, this was a Canadian-wide study, and it was sent out recruitment was done through mostly social media and email, and it was, participants were invited across Canada. Despite being a Canadian study, you can see that the concentration of our sample is in Ontario. We were able to recruit mostly mothers, as you can see from our sample. And it was primarily a mother-son dyad that was the focus of our interview. Although I do have an asterisk there for some participants, parents who had more than one child with substance use disorder. Not surprisingly, and in alignment with a lot of the caregiving literature, the bulk of the sample was women. But that's not to say that the fathers who participated in this study really wanted their voices to be heard as well. For the large part, our sample were older, fell within the older range of 60 to 69, actually young old, I should say. I suppose I'm comparing that to some of our spouses and siblings. 90% of the sample attended higher education, so it was a pretty well-educated sample, and about half were still working full-time. So I'm going to let Angie speak to these themes separately, but just as a very brief overview, we landed on the term alienation, which is a concept that was first introduced in Marxist theory and described how workers became disconnected from the product of their labor. However, in this context, we're looking at how the alienation of the family care work occurs within the system. So this study adopted the concept to describe how affected family members experience their care. We're going to describe 6 ways in which system alienation manifests, and I'll let Angie discuss those. So you just press this button here.
Hi. There we go. We're going to get to hear from the families now, which I'm excited to let you hear their experiences in their own words. There are 6 ways we discovered in which the system alienates families. When I say system, I don't actually just mean healthcare. It includes law enforcement and other agencies. Most of these quotes are from parents. One is from a partner. The first way in which there was family alienation is through professional norms that reflect and foster distrust. So one participant said, and so the entire system is working against the parents to make sure you basically walk away from your kid and leave them to be trafficked, like in the case of my daughter, to be harmed and to die. But the system itself basically rewards the doctor to throw the drug addict, not my word, out and to ignore the family member. The system and the law reward that. And another family member said, but the point is, family was never involved in any kind of assessment of anxiety, depression, bipolar, like what do you think is going on? And you know, I would have said my son is more borderline personality disorder than bipolar, and at times, I still question his diagnosis. So if the family member feels that the professional doesn't have the information they need to make the diagnosis, a natural consequence of that is that they're not going to necessarily believe in the diagnosis, which is obviously problematic. Another way of familial alienation is assigning the family responsibility without providing institutional support. And this quote comes from a mother who tragically lost her 17-year-old son to an overdose. In the months prior to his death, he went missing, and he wasn't in school, obviously. And the Children's Aid Society was basically harassing her for the fact that he wasn't in school. So she said, we went to the provincial municipal police, reported him missing, everybody knew he was missing, and both told me there's nothing they could do. He's 17, he's old enough to be out on the street if he wants to, that at that age, I don't have to keep him home. He doesn't have to stay home, but I'm responsible to make sure he goes to school. I'm responsible to make sure he's not getting in trouble, and if he does, I'm responsible for that, like it blew my mind. So in Canada, we have low barrier harm reduction, but high barrier treatment, and this is another alienating factor. So this mother is talking about the hoops that people have to go through to get into treatment. So she says, you know, he's on a wait list for treatment. You know, it's stupid. He has to call every week, and if he misses a call, he goes to the back of the line. Can you believe it? So that, in other words, these people whose brains are compromised because of addiction are supposed to remember every Friday to call in, and if they don't, they have to leave a message. The people that need it most are the people who will forget to call and go to the back of the line. Is that how our addiction services should be? The people that need it the least, because maybe they've got their act together, are the ones who are going to remember to call. Then there's privacy barriers, which this mother identified as being the main issue for her. This is the biggest policy issue I see, is that I'm the person who knows my son the best, right? I'm the person who understands his triggers, understands his mental health, understands what has worked and what hasn't worked, understands the trauma. He might not even identify with the trauma, but I do, first because I worked as a social worker, but also because he's my son. And for the healthcare system to totally not involve the parent, it's like, it just baffles me. I know, like, I get the whole privacy thing, but like, holy smokes, man. You meet this person for 15 minutes and you think you know. You don't know. I'm the person who does. And then this is the quote from a partner who, you know, has a lot of regret about what she did based on information that she trusted from service providers who were, you know, basically telling her the whole detach with love kind of thing. She said, every piece of advice that I was getting from people that I trusted, people who I thought knew what they were talking about, I really wish that I had done more of the research that I did after my partner died, before he died. Because what his doctor saw is she's in, she's out, she's in, she's out, she's in, she's out, because I couldn't quite be out, because he had no one. I was the only person he had left. And of course, my therapist was like, and whose fault is that? Implying her partner's fault. And the sixth way is neoliberal individualization of sickness, which Oona had to explain to me, means when you focus on the individual sort of to the exclusion of family. And so this is a parent expressing frustration going with her son for him to get Suboxone. So here's your Suboxone. You know, I've gone in with him on a few occasions to speak with the doctor, and they're very much like, he's our patient, we're going to deal with him. They make it very clear that the family's not to be engaged with. So I'm saying to them, this is what we're living with. How can he be helped here? Because he's not doing well, which she feels pretty confident he is not going to tell them. So the consequences of these 6 ways that the system alienates families is that it doesn't just, is that my time up? Okay, I'll really try to speed this up. So it doesn't just alienate the family from the system. When people don't get the help they need, like the family unravels, and it affects relationships sometimes permanently. So here's a frustration of one family member, it's a mom. Because the siblings in our case have all been alienated, I could tell you they're starting their own families. They're not going to drop their lives to support our son in the way we have done. No one's going to do that. We need society to step up and do that. You know, and again, we're lucky we can put a trust, but most people can't do that. And the angst the older people are going through at the end of life, when they should be able to focus on their quality of life for their last remaining days, it should not be full of angst for a child struggling with mental health and addiction issues from the age of 10, who they have been caregiving for their entire life. And last thing, this results in endangerment of the patient, their family, and sometimes the general public. So this is a mother expressing frustration about going to the discharge practices of a hospital. I won't read it, but basically she's saying he's been there like 4 or 5 times. He's ended up, she brings them in, she tells them, I can pick him up, and they never call, and they let him go as soon as they think he's okay to go. And one time he had to walk home 3 hours. It's always at night because he goes in at night, and they let him go. And that is endangering. That's just one example. There were many others.
I know it's time for questions, but just quickly there's lots to discuss here. It's a very complex system. And part of it is stigma, part of it is, history and tradition. Part of it is just convenience within the system. It's so much cleaner and easier to focus on one person. But it's complicated, and it is so much more upstream to look at the family and not just the person with SUD. So we'll end there, and we'll allow for some questions if anyone has any. Thank you.
So thank you very much. And now there's an opportunity for at least one question.
I was wondering if you, through the study, you asked in the different organizations how much training the staff had in family intervention, because like you mentioned in the presentation, working with family could be seen as messy or scary. And I think one of the main barriers to that is that people don't feel confident in being able to work with families. So I was wondering how much training is actually available on how to work with families.
That's a great question. And so this study specifically recruited family members themselves. And so there was a lot of diversity in terms of how resourced the families were. Certainly there was a selection bias in our approach because the families were already resourced either with FAR or whatever way we recruited them. And we know that so many families are not resourced at all, or even just from the television, you could just see how many questions people had. So unfortunately, I don't know the answer to that question, but it's a great question that we need to think about in terms of how to train and equip our service providers, right? Great question.
Okay, so last question from my side. What are your ideas on how to improve treatment services with regard to family members. I was just thinking that what you mentioned just perfectly met the picture that although we know that including family members into treatment certainly has got a very positive impact on the outcomes. On the other hand, quite a lot of professionals, they just feel, well, family members, they're disturbing because they're criticizing me and whatever. But I just wonder how, what your ideas are on how treatment offers could become more inclusive.
So the one thing I would say is our privacy laws. Like I feel like sometimes providers hide behind them. Families understand you can't tell us like the whole, and we don't want to know, frankly, trust me, everything that they're telling you, in their counseling sessions. But there's nothing really preventing the service provider from taking the information from us. And so that would go a very long way. And I don't even think it requires any legislative changes. It's just, and having families come and talk to, like we go and talk every year to the U of T medical students. I think something like that involving families in the training, just like they do, I think now they start to involve people with substance use disorder in the trainings, right?
I just want to say one last thing, and that's that the family also has a history of trauma. And so coming at it from that perspective, that if you see them all as the patient and not just the one identified person, you can have empathy for the whole family and recognize the trauma of the whole group. I think the collective group especially. So yeah, I agree with what Angie said as well.
Wonderful. So we run out of time. A big thank you for your excellent presentation. And to everyone, have a relaxing 10 minutes break before the next session.